we're going to do the second part of the intracranial regulation, and that is traumatic brain injury. Okay, so remember the three ways to do every diagnosis, that what is it, how do we treat it, and what do we teach them. So first we'll start off with what is it. So traumatic brain injury, we can have primary or secondary injuries to the brain. So primary is going to include the traumatic event itself. So that's when you get the contusions, lacerations, your damage to vessels, or those penetrating injuries. Okay. We can usually have blunt or penetrating, and obviously blunt forms would be that trauma, usually from like motor vehicle crashes, and then penetrating like gunshots or stab wounds, things like that. And your second injury is going to be caused by the actual cerebral edema. So that's, or the ischemia in the brain, or ischemia in the brain. So this could be from chemical changes, could be, again, the hemorrhage after the trauma, increased intracranial pressure, edema, infection, and, yeah, brain damage. So that's the secondary. So it's usually what's going to occur after we have that traumatic event. Okay. Traumatic brain injuries can also be closed or open. And this is what I was just talking about before with the blunt versus penetrating. So obviously your blunt would be your closed. This might include some of those acceleration decel injuries for motor vehicle crashes. And of course our open is the penetrating of the skull. Okay, so there's multiple types of traumatic brain injuries. First we have concussion, and that's basically, it's microscopic, and it has diffuse tissue to the brain. Okay. Sorry, diffuse damage to the brain tissue. Okay, so that's our concussion. And contusions are just what they're called, right? They're just brain bleeding, or brain bruising. Usually they don't have any symptoms, really depends on the amount of damage that's with the edema. So if they have longer periods of unconsciousness, usually they're going to have more neuro issues and different vital sign changes. Our diffuse axonal injury, that's when we actually have axon damage in the brain. This is going to be an immediate coma. Okay? Usually they're going to have a CT or MRI to confirm that diffuse axonal injury. In our intracranial bleeding, we actually have kind of subclasses. We can have epidural, subdural, hemorrhage, and hematoma. So our epidural bleeds are going to be when the blood is actually stuck between the dura and the skull. Okay, so this is an emergent situation. So epidural will actually only have minutes before it's going to decompress that brain before it can cause herniation. If you guys remember from the last lecture, herniation is bad, right? That's a dead disease. Okay, so epidural is horrible. The subdural, and you can have both, acute and chronic. The subdural is actually blood that gets stuck between the dura and the brain. So in an acute condition, a craniotomy can probably help to drain that bleed, but a chronic, it's a slow bleed. So this is typically seen in older adults. Sometimes can be caused by falls, and it's just kind of like they might have a minor head injury, and it's just a slow bleed that turns into a huge problem later. Okay. And then obviously we have our hemorrhaging and hematomas. This may not need surgical intervention, but you will have to monitor your ICP. Right. So, depending on where the injury occurs, you can see different types of injuries, right? So we have a scalp injury. Initially this is going to be heavy bleeding because of all the small capillaries near our scalp, and it's going to increase the risk of infection. If there's a lot more area to cover, there's a lot more areas for infection to grow. Okay. In a skull fracture, you're going to see more of a localized pain, and you actually might see two different signs based on where the skull fracture is. So in our skull fractures, we might see what's called battle sign or halo sign. And battle sign is usually going to be for our basilar skull fracture. Okay. And the battle sign kind of looks like bleeding out of the nose and the ears. So you're going to see bruising bruising behind the ears, and you might see some bruising under the eyes. Okay, so it looks like they've been in a battle. In halo sign, this is actually a CSF leak, and you're going to you might see some drainage coming out of the nose or the ears. But the best way to see this halo sign is actually a drainage from the ears that kind of lands on the pillow. And since it's like an oil, it'll actually make like a little ring of fluid. So that's how they can usually tell that's CSF that's leaked out of those ears. Okay, so what are you going to expect to assess in these clients? Right? You're obviously going to want to take your whole health history, try to get a baseline of the neuro status before the accident. Definitely going to focus on the time and the cause of the brain injury, and of course, like what caused it. So the force of the blow, was it penetrating, was it blunt, just to get that baseline level of consciousness. We're going to be using our Glasgow Coma Scale a lot, okay, to make sure there's no slight changes at all, because that should be your first sign of anything going on neurologically, and that's that altered level of consciousness. You're definitely going to be looking at pupils, remember from your ICP lecture. So if you look at the unilateral pupils, if one's getting bigger, one's getting smaller, could be a sign of herniation. Also, they might see some pinpoint pupils, or you can see some wide dilated and kind of fixed pupils. And usually that's the sign of brain death. Okay. We're going to definitely look for sudden onset in neurological function, so different movements, change in reflexes, definitely changes in vital signs, headaches, and of course any seizures. Okay, so this could indicate that increased intracranial pressure. So how do we treat it? Okay. Obviously, most of the traumatic brain injuries are going to require some sort of surgery, especially if it's a brain bleed. They're going to want to do those craniotomies to help drain it, but mostly it's going to be a lot of nursing intervention. Okay, so these are all the nursing diagnoses that could be related to traumatic brain injury. We want to think about when we're treating that ineffective airway, these people are probably going to be on mechanical ventilation. We're going to look for any changes in breathing. We're definitely going to have ineffective cerebral perfusion. Okay, so you're going to have to, you might have increased intracranial pressure, so our interventions are going to be trying to decrease that pressure. So again, remember, it's all about the positioning. If you want to get some venous drainage, you're trying to get that pressure off the brain. They might even bring in medications like mannitol, okay, some of those osmotic diuretics. Okay. You're going to need to either give or restrict fluids, depending on the injury itself. They definitely want to consider nutrition. Most likely these patients would probably be on a TPN, as they're not going to be conscious to start eating. Okay. Definitely risk for injury. We were going to monitor them from seizures and altered levels of consciousness. So you're going to put those seizure precautions on your patient's bed. We're going to look at those body temperatures. Again, these are going to be those CNS fevers. So you might see those 104, 105, 106 range. So you might have a cooling blanket on top of these patients and maybe even a rectal probe, so you have a constant temperature. Right, they're definitely at risk for impaired skin integrity, so you're going to want to make sure you're padding and rolling. Okay. I have disturbed thought patterns on here. All of these are kind of, the last ones are the psychosocial ones. We're really going to have to take care of the family. If that patient is conscious, okay, we definitely have to reorient them if they do become confused at any time. And it's really going to be, basically we're supporting the family through this process. So what do we teach them? Mainly for these guys, it's going to be more post-op care. So if they have that craniotomy, looking for signs and symptoms of infection, maybe when to go get their staples removed, but typically in craniotomies, they're usually removed before they leave the hospital. But just in case, they're obviously going to want to make those follow-up appointments. And then any safety concerns. If it was a motor vehicle accident and they weren't wearing a seatbelt, this is a good time to bring in that primary prevention. So wear a seatbelt, wear a helmet, things of that nature. And that is what I have for traumatic brain injury.